go ahead and get started. It's about that time. So I'm Melissa Holland, and I'm the Executive Director of the Oklahoma Assisted Living Association. So thank you guys for having me here to talk. Allergies are acting up, so taking some medications. It's a little dry. So probably just a little TMI. So, okay, so I am going to preference a little something. I do have like a couple of jokes in here in my presentation. So if you guys will laugh, it makes me feel a little better. But, and then if you just have any questions, ask along the way. But one of the things I like to do is I do like to start out and do a little education or just, and you guys may have already had some of this, but just a little briefing on long-term care as a whole, because sometimes people get confused, and Z did say that this may kind of stop, so we'll click the mouse to get that going, maybe not. All right, see, it's not going. Oh, there we go. All right. So a little bit about long-term care options in Oklahoma. So a little bit of a history lesson here for you. So the first thing that actually happened and what our lawmakers did is we had our nursing homes. And so that's what you guys are here to do, is to become a nursing home administrator. And so nursing facility that provides the 24-hour skilled nursing care and related services for residents who require Medicare or medical or nursing care. So that started in October 1st of 1980. That's when it became law, the Nursing Home Care Act, and it was licensed by the Oklahoma State Department of Health. It does require a certificate of need. So you have to file for the certificate of need if you're wanting to open up a brand new one. Now, little unknown fact kind of like this, or you guys may realize this, but if you own a nursing home that has the certificate of needs and say you're not going to use that, or if it's shut down, that's like gold though in Oklahoma. So it's almost like mineral rights in a way, because they're hard to get. So you'll see that sometimes people still pay for that licensure to keep those beds licensed in case someone wants to come in and purchase that. So if you've already had that certificate of need and you have those licensed beds in a place, they may not be operating, but they're still paying for them. And it does have options for Medicare and Medicaid. So the next thing that happened was our residential care. Oklahoma was a little bit ahead of its time in a way. And so this does provide residential accommodations, food service, and supportive assistance. And they may also provide assistance with meals, dressing, bathing, or personal needs and medication administration. But they cannot provide medical care such as skilled nursing. So that's the one thing that you do not find in residential care. And that was November 1st of 1984. And it is the Residential Care Act, and there is no certificate of need required. So anybody can decide they want to open a residential care and start building it, or, I mean, obviously they have to go through the licensure process with the health department. And there are no options for a Medicare or Medicaid. So the next came our adult daycare centers, and that does provide health, recreation, social, and supportive services to impaired adults. Participants do not stay overnight, and that was November 1st of 1989. The Adult Daycare Act, licensed by the Health Department, no certificate of need required there as well. And there are no Medicare or Medicaid options, though DHS does have, you know, with the Advantage waiver, they do pay for that. And then came the assisted living community. So that's a home or establishment that may provide assistance with personal care. We do not provide 24-hour skilled nursing care. And that happened May 20th in 1997 under the Continuum of Care and Assisted Living Act, licensed by the Health Department. No certificate of need required for assisted living. And no Medicare or Medicaid option, but through DHS you can have that Advantage waiver. Around 8 to 10 assisted livings that have that about now. And then you have your continuing care facility, and that's where you combine the services of a nursing facility with an assisted living center and adult day. Is licensed under the Continuum Care Act and must also meet requirements applicable to the nursing facility. So if you do have that, and it's same birthday, the May 20th of 97, Continuum of Care and Assisted Living Act, licensed by the Oklahoma State Department of Health. They do have the options for your Medicare and Medicaid for that nursing home portion, and you have to have a certificate of need for your nursing home portion. So currently in Oklahoma, all the Continuum of Cares have assisted livings only. None of them have adult daycare with them. So. And then the Veteran Centers, that actually was created in 2013. That they were out there, but they just weren't licensed by the health department. And so it is for residents or veterans living in state veteran centers. And they're licensed as nursing facilities and can provide a 24-hour skilled nursing care. And that happened May 29th of 2013, and it does fall underneath the Nursing Home Care Act, licensed by the health department. And the certificate of need is not required for current or future veteran homes. So they do not have to get one of those if they decide they want to open up a new one. But it does provide some. And then you have your independent living or senior homes. This is one of the things I like to help educate people on, because sometimes when they go to independent living, they think they're going to a licensed home, like licensed assisted living or something. The state's going to look over it, and they don't. So these are apartments, cottages, and single family homes, and they do not require assistance with daily activities or 24-hour skilled nursing, but they may benefit from convenient services. It's not licensed, but they may have a very high acuity that is receiving home health or hospice services, even high enough acuity that they should probably be in nursing homes, not just assisted living, but nursing homes. And a lot of people go there because they cannot, a lot of assisted livings may not, they don't meet the requirements for moving in. And so, and they don't want to go to a nursing home sometimes, but they have the nursing home care. They need that. And they just bring in home health or hospice services. Sometimes it's kind of scary. So, all right, let's talk about another thing that I like to educate when we do our administrator for the OKALA regulation versus rules, because sometimes you get a little confused. So what is a regulation? What is a rule? Because sometimes people talk about them, you know, simultaneously or in and out. But a regulation, that's your law. So that's what the lawmakers make. So when you hear that, you'll hear an act or regulation or law. All three of those are one and the same. And then state legislators write into law what we must follow. Under nursing homes, you also have the federal law too. So you have two sets of laws that you have to follow. In assisted living, we just have our state laws, unless it's like employment law or, you know, things like that. Sometimes it's referred to as an act, and usually law is very brief and not defined in extensive detail. They just kind of write it out. The rule, these also you have to follow, and they, legislators usually write into it who will promulgate the rules into an act. So they want the experts to make the rules and define those out bigger and longer, because like they'll say like the health department will promulgate the rules, or with OSBELCA, they will promulgate the rules that oversee the administrators, because they're the experts, not our lawmakers. And so usually a regulation may have rules, but the regulations is usually so brief that you don't ever have that problem. So now we're going to really get into assisted living. So our important dates was May 20th of 1997. That was our birthday. That's when it became law. But it took a whole year for the Board of Health to adopt rules for the continuum care and assisted living. So a whole rule before we had, or a whole year before those rules were actually out for us to be able to start getting up and operating. And then in June 25th of 2007, the licensure rules became effective regarding plan of accommodations, because about 10 years later, people were living there and they're like, well, I don't want to move out, you know, just because maybe I can no longer ambulate as well as I could have, and so I want to stay here. So they adopted the rules regarding plan of accommodations. Well, then the fire marshal's like, hold up, we need to make sure you can evacuate. And so then we had to do a little grandfathering effect about the fire marshal building occupancy codes and plans of accommodations. And then the laws were amended in November 1st of 2011, which brought the assisted living administrators to be, that's when we came underneath OSPELCA. That's also adult daycare and residential care. So we all came underneath OSPELCA like nursing home. And then on November 1st, 2013, the law was amended to add informal dispute resolution. So in assisted living, we never had that. So when you got surveyed, what you got was what you got. And I mean, you just had to go with it. So there was no option to do an informal dispute. And so we kind of took a little bit from what the nursing home had and then kind of changed, you know, did a little difference with that, but we added that into the process. So if someone felt like what, you know, on their survey it wasn't right, or they didn't have a chance to show them the documentation, that gave them an opportunity to dispute it. And then 2016, we did amend, and these were actually, these laws were ones that OKALA did. So we amended to address scope and severity during the survey, and also address not being able to find under residents' rights, because, you know, everything can be, you know, they'll tag you under residents' rights for everything. But say if you were tagged under residents' rights for a medication administration, and then they came back to clear it, and they you cleared medication administration, but then they re-tagged you under residents' rights, maybe because laundry wasn't done. Those are two totally separate instances, but then now fines are starting. And so we wanted it to be, it has to be the same thing that you didn't clear, because everything can go under residents' rights. And so it has to be under, it cannot be an unrelated deficient practice when they're starting to fine. And then in 2016, we had the laws amended so that OSPELCA added the electronic testing option for state standards. And one of the reasons for that was because we were having individuals come from out of state to take our course, and then it was just hard for them to get back to take the state standards. When you guys take your course here, it's like usually like right in as part of it, and that isn't how ours was. And so it does make it easier for because a lot of like regional directors or that lived out of state, and it was hard for them to get back to take the class, to take the state standard. So now they do it like through PSI if you need to. And then November 1st of 2019, we had the laws amended, a makeup of the administrators or the people that represent the board. When we're getting down to trying to find individuals that could serve, especially for like residential care and adult day. It used to be 5 years, and so it's down to 3 years. Nursing home still has to be 5 years, but I'm just trying to, and then also making sure that they have the experience in the administrator facility type that they're going to represent. Because just because you may be able to be an administrator in an assisted living, if you haven't sat behind that desk and been there and done that, how can you represent, you know, an assisted living on a board that, you know, governs them? So we wanted that to happen. All right, so why the need for assisted living? So it came about for consumer choice. So it allows for care plans and room setting to be adjusted to meet each resident's needs and capabilities. So as people age, they might not have to move when they start to have more needs. And then it also, the consumer can choose a facility that offers services to meet current and future needs. So instead of being limited where they currently were at in a residential care setting or a nursing facility, this just kind of added something in between in Oklahoma. So that's kind of how that came about. And it also provided flexibility for the provider. So existing residential care and nursing facility providers, they could continue operating underneath that current license. The continuum cares could either add the assisted livings, you know, to have like that step up procedure. And then like a lot of residential cares, some of them went ahead and just switched over to assisted living. Some stayed residential care. But I think, have you already had residential care portion? Have y'all? Has Denise talked with you? Okay. So residential care, the way their regulations are, you have to be at least 18 to move into residential care. But with assisted living, it's usually an older age. And so there was more that kind of defined the population that you're going to serve a little bit more. And so it kind of filled that gap that they were looking for. So here's some facts about assisted living. All assisted living is regulated at the state level. So when you go from state to state to state, your regulations are going to be totally different. So you may see a little similarities, but they're all regulated different. So each state will have different licensures and different regulations and rules. Oklahoma is one of the most regulated states for assisted living, and that's really not a bad thing. That just means that we have more rules and regulations in place to ensure that the seniors of Oklahoma are better cared for. Once you kind of learn it, you're like, oh, that is kind of good. So if you look at Texas, they actually, and you guys you won't believe this, but in an assisted living, for someone to administer medications, like I could go there and all I have to do is be in service by the nurse. So anybody off the street, and then they can administer medications. Doesn't that scare you? Any nurses in here? Yeah, way scares you, doesn't it? But that's how it is in Texas. So I like our regulations for that purpose.
Arkansas doesn't have maids, so nurses do.
Really? Yeah. And we are also the only state that has residential care, because other states, residential care equals assisted living. So that's why we have the RCAL license, because NAB does it for residential care assisted living, because other states, if they say residential care, it's the same as assisted living. So I always have to explain to people our residential care is something totally different.
I have a question.
Yes.
Residential care, isn't that more for mentally ill individuals?
You do find that. So like each community is a little different, but that's really, you're going to find a lot of mental health needs in there. A lot of them go out for day treatments. And so you do find that. There are still some that serve a senior population, but most of them, like some you'll see they serve a lot of veterans that may have like PTSD, or they just need help with you know, taking their medications and that, so an older population, but it is a lot of mental health, and it's much needed. And for a while, we were losing a lot of residential cares, but now I'm seeing more people starting up some newer ones. So it actually is a really good thing in place that we have in Oklahoma. But if you've seen one assisted living, you have only seen one. And I like to tell people that is because the thing about assisted living is the choice. And whenever you fill out your application for licensure, you determine to a specific, or to a certain extent, to the degree of the acuity that you're going to keep in your assisted living. So some will keep individuals with incontinence and some will not. And so whenever you go to look for an assisted living, these are questions you need to ask. And some will allow aging in place, some will not. So it just depends on each individual assisted living, and each one has a different culture inside of it. And so that's why you have to do research, and try not to do that research whenever you've gone to the hospital and the discharge planner says your mom can't go home. And that's usually what happens, but you need to do that before then. And memory care is not a separate license in Oklahoma. Same thing with your nursing home. If you have a memory care wing or something and it's with your nursing homes, it's still under your nursing home license. So other states you may see just a memory care license, and that's not enough. So here's the definition of assisted living. So that means any home or establishment offering, coordinating, and providing services to 2 or more persons who basically live there, are not related to the operator, and by choice or function impairments, they need assistance with personal care or nursing supervision, need intermittent or unscheduled nursing care. So that's why we have like home health that come in and help. And may need medication assistance, and really pretty much That's one of the #1 reasons they move in. They need medication help and assistance with transfer or ambulation. And intermittent nursing care, I just kind of said that, but home health aid services may be provided. So I've been trying to take out some of those. So here's a few little statistics. So in 2008, we had 117 assisted living communities with 6,753 beds. In 2019, at the end of the fiscal year, 184 assisted living communities with 11,186 licensed beds. So the growth, we are the fastest growing long-term care in Oklahoma. So we have 67 assisted living communities and gained 4,433 licensed beds. But keep in mind, the way assisted livings license their beds is that they will license, like say if you have a 60-bed assisted living, they probably have 45 doors. They're not going to be caring for 60 residents. They just do that in case like a husband and wife wants to move in, or in case, you know, some people want to share, but it's not going to be double occupancy all the time at all. They will hardly ever get to 60 people in that building. But in nursing homes, usually you guys are going to have that double occupancy. So when you look at the beds, it's not like that in assisted livings. But the average assisted living community is a 59-bed, largest is 166, and the smallest is a 5-bed. And so that 5-bed is what you're seeing is in like a residential neighborhood, and they bought like a 3-bedroom home and they've licensed it for 5 beds. And so those are getting kind of popular, especially in other states. And so we're starting to see some of those in Oklahoma. So care and services. So service and assisted living, it shall not care for any resident needing care in excess of the level they are licensed. Remember how I said when you fill out your licensure, or capable of providing. And one of the things I like to always tell our members and stuff, capable of providing has to do with, even if you want to provide that, but if you continually don't have the staff to provide the care, that means you are not capable of providing that care. And so you need to have a hard discussion of if you're doing the right thing for that resident. And if you're not, then you probably need to discharge them if you cannot provide that care. And that goes with aging in place. So, and ensure routines of care provision and service delivery are directed by the resident to the maximum extent possible. So you do need to include your resident in your care planning. So admission criteria. So you should include the description of the population admitted based on services provided to meet the following needs. So that would be your personal care assistance, nursing supervision. A lot of people, sometimes, you know, I'll get complaints from the health department. Lisa McAllister has called me before and says, we're really getting complaints, like people are calling and saying, why don't they have a nurse 24/7? And I'm like, and she has to explain to them, they're not required to do that. And so I'll try to remind my members, like during their marketing materials and stuff, or when they're doing that, remind people that a nurse may be on call, but there's not one in the building 24/7. So, and how you're going to meet the needs or services on unscheduled nursing care. Medication administration, assistance with transfer or ambulation, and assistance with cognitive orientation and care service for the Alzheimer's disease and related dementia. And so the description of service in assisted living, so you need to provide or arrange, this is going to be included in your application for the license and also your contract. So whenever we get surveyed, they look at our licensure, they also look at the contract and the marketing material, because all of that is one, and we have to ensure that, especially if there's complaints, that you're providing everything that you say you're going to do. And so, you have to say how we're going to do the assistance with that personal care, meals, housekeeping, and laundry, the nursing supervision. We kind of talked about that, medication administration, all of those. Assistance with transfer ambulation. One of the things I also tell our members is if you decide you're going to take a 2-person assist, you need to remember that in the event of emergency, 2 people go to that 1 person. You have to have enough staff to take care of everyone else. So if you have two-person assists, 4 of your staff are going to those 2 people and enough staff for everyone else. And so a lot of them, you'll see like this deer in the headlight look whenever I'm explaining that, so that they can understand, can they meet the needs if they have more than one 2-person assist or even just a 2-person assist. They've really got to consider that. And then plan programs for socialization, activities, and exercise, and provision for evacuation. So that's what we just kind of talked about in the event of emergencies, if you have individuals that need help on that. Okay, here's your time to laugh. So anyway, so resident admissions. So no whippersnappers are allowed. You know how some older people, they really like to say whippersnapper to the younger ones. So anyway, that's my joke. Okay, so how do we admit? So prior to admission and move-in, this is what has to happen. So you have to have a resident assessment. And so who can do assessments? Right, so a nurse. And so an LPN can gather the information, but an RN has to do, the full. And then a physician plan of care. So when a physician looks at this physician plan of care, like, because one time my mom was going to go for a respite stay, and I had it for the physician, he looks at me, he's like, well, who fills that out? I'm like, well, you do. But usually your nurse is going to, and then you'll probably sign it, because they're like, what? But sometimes those are hard to get done. It's amazing we even get move-ins with this. But because you guys just get orders faxed over. We have to have this whole physician plan of care done. And then we have to do a contract. So it's kind of like an apartment lease contract. So we have to have that done. And then the insurance fee and rent. So all of that has to get taken care of before they can even step foot into the community. So signed, sealed, and delivered. And then our staffing requirements. So this is what is in rules and regulations. So a nurse, so that's an RN, so an RN consultant to oversee the skilled nursing interventions, medication staff, so you have to have staff to give medications, and then an administrator. And then a dietary consultant only if you are providing specialized diets. So a little bit more on staff qualifications is they do have to pass the national fingerprint background check, which that's kind of all of us. And then if they're providing socialization, so like activities, they must be trained. So they don't have to go through the whole week-long course and do all this documentation. They just have to be trained. And then if they're in a specialized unit, so like a memory care, they have to be trained prior to actually working in that unit. And then direct care staff has to be trained in first aid CPR. So they don't have to be, carry the current certificate, they just have to be trained in it. I don't know how that one got by, but that's what it is. And then all staff must have 1 hour dementia training per year. So, and you guys the same way. So every direct care staff has to have that. So minimum staff requirements. So there it is. Adequately trained staff shall be on duty 24/7. So we don't have any ratios. And so, which the health department likes this, because if residents don't, if it looks like we're not meeting their needs, then you don't have adequate staff. So you have to make sure you have enough staff to meet the needs of the residents. So it's very gray, a very gray line. So you just look at your acuity and have your staffing, the staffing pattern for it. There are a few things. If you're going to have a 1-person staffing, which sometimes you might see that and say, remember that 5-bed we talked about? So you may see that at night, but they have to be they have to be able to give medications. And so, and if you're going to do that, then has to be in your lease contract. Health department has to know, and then of course the family members and the residents have to know there's going to be 1-person staff. And then also, if you have a unit that limits access, so say if you have your assisted living and you have a memory care wing, the staff in that memory care wing is for the memory care, and the staff in the assisted, you can't share, and you have to have designated staff there. And you have to have medication aids in each one. You can't have one passing meds here and then coming over and passing meds there. It doesn't work like that. So typical staffing in assisted living. So usually you'll have an administrator, activity director, a nurse, which they call the director of wellness sometimes, a dietary supervisor, marketing, and maintenance. Sometimes you may share a maintenance person with another place. And then a direct care at a minimum, so at that average at 49, you may see a little bit more, but you'll have at least an ACMA, a CNA, and a cook per shift. You may have 2 CNAs if it's like full or depending on acuity. And then if you have larger communities, then you'll see like a business office manager, housekeeper, laundry aide, maybe a resident care coordinator, and a dietary aide. So in the smaller, these are kind of your smaller communities. And then they'll just add staff, like the direct care staff based off of acuity and the needs of the residents during certain shift times. But that's a minimum of what you might see in the small ones. So as administrator, you're a working administrator. You're not delegating a lot at all. I mean, it's you. So what is the cost? So in Oklahoma, it's pretty much all private pay. An average cost right now is about $3,751 in a private room. It's going to depend on the size you pick and the amenities of wherever you're going. That's about your average cost. There is some financial insurance if you have long-term care insurance, the VA aid and attendance, and then tribal assistance. Each tribe is different. Whenever I was an administrator, I had a resident that we got a check every month from her tribe, but each one's different because they do take care of their elders. And then the Advantage waiver. And then there is a group called Life Care Funding Group, and so that's where they take care of your life insurance, and basically they're going to be the beneficiary, and then they'll pay for it. So some people do that. And how is it figured? So you have your basic rate, you'll have a care rate, and then additional costs. So the basic rate, like I was saying, is based on the room style chosen, and it includes your basic services. The care rate, there's different ways, like you may have a tiered service that's bundled, all inclusive, or a la carte. So it's just like, it just depends on which company and where you go. And then additional costs, extra services, could be a room tray service, extra laundry. When I was administrator, I had a resident that her family invented, you know, the big round bay hells, and then you see on the back of the trucks that poker thing that they put them on. Their family invented that. And so she wanted breakfast in bed every morning, and she got that. And they paid for it, but that's what she wanted. So, but anyway, so personal care products, so medication costs that may not be covered by insurance, incontinence products, we don't provide that, and toiletries, including toilet paper, because we don't provide that either, because they're like living in their own apartment, so they had to provide all that stuff. So what is included in your basic services? So that would be your 24-hour staffing to meet scheduled and unscheduled needs. So you have to make sure that you're thinking about that. The 3 meals a day and snacks in between those meals, the housekeeping services, scheduled transportation. So scheduled is a key word. And then scheduled activities. Your emergency call system, if it's in your contract. And then basic amenities would be a private or semi-private rooms, the private bath or semi-private bathroom, common living areas, dining rooms, activity room, laundry room, and then barber shop that you really, they usually pay for the services. Other amenities, maybe a small bathroom, theater room. You should see some of these theater rooms. I mean, they're pretty cool. Private dining room, chapel, safe rooms, libraries, gym, exercise room, a coffee bar bistro, a game room, even indoor swimming pools. So there's some pretty nice fancy ones out there. So why do people move out? Death, that does occur. Their acuity, and sometimes it is they need more assistance, or they're moving back home. They may have come just for temporarily and they've gotten better and they go back home. Financial, some may have lived there longer and outspent their money, but a lot of times, if that's the case, usually if they've been there for 10 years or a long, long time, a lot of the companies work with them. I mean, that's kind of harsh. I mean, just saying, nope, you gotta go, but they usually don't do that. Dissatisfied. And they may not be receiving the care services they thought they were going to receive. And there are also some people that no matter what, you're just not going to make them happy. But they could be unhappy with staff. They may not like the food. And this is going to be true across the board. If you make their bellies happy, their tummies happy, they're going to be forgiving on some other things. So just remember that. Your dietary manager is like your go-to. Other residents, I mean, there are some mean residents. Residents bully, even in the seniors, they do. So there's some mean ones out there. No activities. So, or location. Sometimes, they moved into one close to where they live, but then their children live somewhere else, and so they may want to move closer to their children. So I'm going to tell you a little bit about our top 10 in our state survey, which you guys may relate a little or know. But so staff qualifications. So assisted living center direct care staff shall be trained in first aid and CPR. As an administrator, if you ever get tagged on this, you're just going to need to go to a wall and start banging your head, because you should always have this updated. Yours are going to be certified, but you just have a little spreadsheet. You just keep track and make sure your staff always have that. This is a no-brainer. So don't ever have this one on. But use of assessment. So the results of the resident's assessment shall be used to develop a care plan for the resident in consultation with the resident. This kind of results from whenever they do an assessment, if they're not following that assessment in the care plan, or if the resident's falling and they're not reevaluating the assessment and using that the way it should be. Criminal history background check. One of the things that happened on this, it was kind of a little hot point this last year, is that under the OK screen, whenever it would pop up, like if you went to hire someone like a rehire, and even if it was over a year, it would come up and say, this is a duplicate, do you want to continue? And so a lot of people were getting confused, and they were saying, oh, they were thinking, oh, I've already done that one, I don't need to continue. And so they would say no. And so they weren't getting a more recent background check. And this is what was happening this last year. So when they were asking for them, they didn't have a current background check. And so once some of my members started telling me about this, so I kind of put the word out, your answer is yes, you want to continue because you need to get that. So remember, if it's over a year or the 6 months or whatever that was, your answer is going to be yes, you want to continue and get that current background check. But that's what was happening in OK Screen. I think they had done an update and then put that little pop-up screen in there. And so people were getting confused. So that's why this one happened. And maintenance of records. So there shall be an organized, accurate clinical record, typewritten, electronic, or legibly written with pen and ink for each resident admitted, and it shall document all their services provided under the direction of a licensed healthcare professional, consistent with professional standards of practice. And I think that there's just some people that were dropping the ball when they were having new move-ins, and they were not getting their charts put together, like the resident charts put together. So, and not putting everything in the way it should be from the surveys I was looking at on that. And then residents' rights. So this had to do with mental and physical abuse and neglect. And really it was about on the, on the chemical and physical restraints. This was a hot topic this last year. Usually this one had been dropped out of the top 10 and it came back in. I think there's just some bad actors out there in 2019 that got this one in there. And then assessment timeframes, so making sure that within 14 days after admission, and then once every 12 months or after a significant change in the resident's condition. And the significant change is the key point. There were, again, some bad actors that they were not utilizing their RN or having an RN like they should. And so significant changes were not being taken care of like they should have. And then food storage preparation and service. So we have to follow chapter 257 of this title, and you guys do too. So as an administrator, I'm going to tell you guys this. Keep in your desk, write this down. You're going to keep an extra hairnet in your desk, an extra food thermometer, and lots of Sharpies, like a whole package of Sharpies. Because on food truck day, no one's going to be able to find a Sharpie in the dining room. And you're going to need that. Extra hairnet and Sharpies and a food thermometer. And then weekly, you want to at least walk in your kitchen. You're going to trust but verify. You're going to make sure those food temperatures are being done. Because a surveyor does not want to see food temperatures that are all in the same handwriting in the same color of pen. And it looks perfect because food's going to be on that. Like it's going to look like it has been spilt on, the dog bit it and whatever. That's the true, what it's going to look like. But if it's all perfect, same handwriting, they know they just did it. So you're going to walk that. The other thing that you want to make sure of, if you have on your dishwasher, if you're using those sanitizer strips, you're going to want to check expiration dates because those expire often, very fast. You're going to want to make sure that's done and documented because those are the biggest tags across the board that all long-term care get. So there's nothing worse than having a perfect survey and then you're going to get tagged in the kitchen. And this is across the board for all long-term care. Okay? All right. So next is number 3 is going to be our care and services, the coordination of care. So an assisted living center shall not care for any resident that needs care in excess of the level of care or that we are capable of providing. But the key thing next is the center shall monitor and ensure delivery of home care and hospice services. So we have to get that care coordinated and ensure that they are doing what they say they're going to do. And one of the hardest things is monitoring everyone that comes in and out for a nurse. And so, yes, residents have the right to choose who they're receiving services from, but you also have kind of the right to limit how many, because a nurse cannot monitor 50 different home healths and hospices. And in your case, it's going to be hospices. They cannot monitor that many. So it's okay to give them a list of choices that come into your community, so, or your facility. So remember that, because sometimes people think, I have to give them a choice and anybody and everybody can come in. Well, your nurse will never be able to manage that. And then medication staffing. So in assisted living, one of the things that, since we don't have, you know, a medical physician over it, so we do have our medications have to be reviewed monthly by an RN, and then at least quarterly by a pharmacist consultant. And so you have to have that on file. I mean, the pharmacist to look those over. So in this case, I think it goes back to there were some people that didn't have their RN consultants in place, and again, so just some bad actors and some things and some balls were dropped next to our end that was not reviewing that. But the other thing is if you have medical records, make sure that it where people are signing off, that is clear and consistent. So that's a problem too when you have the like the medical records that are computerized, because sometimes people don't sign where they're supposed to, or even with the MARS with your staff and their initials, you still need to make sure that their signature's going and then you have their initials. And that's where some of this happens. So even they may be coming in and doing what they're supposed to do, and they have it on their on the computer, but then whenever you go to print it off, nothing is showing there to show that they've actually signed off on it. So a lot of that is happening. So ensure that you have those policies and procedures in place to ensure that that's showing. Okay, and then number one, again, residents' rights. And this one is about they have the right to receive adequate and appropriate medical care, be fully informed, participate in planning and treatment, and right to use medication and treatment. And this one has been this one's been number one for like 5 years. And a lot of it has to do with medication administration and the medications not being in the communities, because residents have the right to choose their pharmacy. So you guys, because you're ordering them and it's coming through Medicare or Medicaid, which, you just order them bubble pack and it's there. No, we have to give them a choice. And so sometimes family members say, oh, we'll bring that in, or we're going to go to Joe's Pharmacy down the corner and we'll get that, you know. And so talk about a nightmare on coordinating getting medications in your community. Nightmare. So you add that with the diversion of drugs, which you guys know about that too. So then this ends up being our number one. So unfortunately. But if you, okay, so let me go back to that diversion real quick. If you guys tend to have a problem, and if you're in the metro area, like a big area, get a hold of the Bureau of Narcotics and they will help you set up like the sting operation or whatever you need to do to figure out where it's being diverted. So they're really good about helping with that. Okay, so now I'm gonna do a little comparison of assisted living versus nursing homes. Just to show you a little bit. So we're regulated at the state level. And then you guys have the Title 19 and federal, federal regulations. We mainly deal with the residents, so we're dealing with them a lot. You guys kind of deal with family a little bit more. We have more of a home-like environment. Yours is a little bit more institutional. However, a lot of nursing homes are doing a lot of makeovers and are really looking, kind of going towards more of that home-like environment. So we have the occasional skilled nursing, which you guys have the 24 licensed nursing needs. We're primarily private pay. You have the Medicare, Medicaid, depending on if you're the skilled nursing unit or. We have a licensed nurse on call 24/7, which you guys have them on each shift. No required employee to resident ratio, and you have a higher employee to resident ratio, which is determined by your regulations. And then we do not have MDS. So, what you guys do. And then no certificate of need, and we have an RN consultant. And so you have a certificate of need, and your DON is usually your RN. So a little bit other on the comparison is like in 2018, we had 117. Nursing homes were 317. And in 2020, we had 184, you had 304. So losing some. And the little asterisk you'll see here in a little bit, that does not include some certain places, but so we had an increase. The average bed is 59, which the average nursing home bed is 93. And largest 166, largest is 375. Smallest 5, and the smallest nursing home is 8. And I believe it's a ventilator unit in eastern Oklahoma on that. But it does not include your VA nursing homes or the specialized facilities for individuals with intellectual disabilities on those stats. So, because whenever in 2008, the VA homes weren't included, so I didn't put that in there. Here's a little bit more. So we're going to talk a little bit about surveys. So in surveys in 2020, and it really should be 2019, but the report from the health department's labeled 2020, so it came out January 2020. So 2019, they did 357 surveys and for assisted livings and nursing home 2018, which a decrease of 103, a decrease of 61. So approximately 1.94 per community and approximately 7.29 visits per home. So you can see the health department is in nursing homes a lot more often than assisted livings. Number of complaints of surveys were 89, which was a decrease of 58 from last year, so about 0.48 per community. Number of complaints, 961, which was an increase of 6, approximately 3.16 per home. Some homes may have 0, but it was just kind of, dividing it out on that. Okay, there we go. Okay, so here's another little statistic. This I've added for the first time, because obviously COVID's here now. But so are you safe from COVID in long-term care? So sometimes, some of people ask for individuals over 65, and he asks, are they safer at home or in long-term care? You're much safer in assisted living in Oklahoma. And I pulled these from August 20th because I was preparing this early. So in the state of Oklahoma, so we're going to compare state of Oklahoma, assisted living, nursing homes, and actually I have CCRC and residential care, so they'll come up. Yeah, there we go. So the total deaths over 65 were 559. So of those, 44 have happened in assisted livings, 224 in nursing homes. But keep in comparison, like how many nursing homes, compared to how many assisted livings are out there. So keep that comparison, like what there were 600, so. CCRC is 19 and residential care is 0. So these are like total deaths. So you'll see the percentage of total deaths over 65 and then how many happened in our long-term care. So 7.9% assisted livings, 40% nursing home, 3.4% in CCRCs and 0 in residential care. So the number of facilities that have had COVID in them, so if you'll look, so 62 of the 184 of assisted living, so approximately 34%. Of the nursing homes, approximately 60%. And in the CCRCs, which is crazy, approximately 84% have had COVID, but yet their death rate is really low. Really low. So that's really good. And then the residential cares, they just kind of started getting it. It's really mainly employees that, not their residents that are getting it. So it does tell you that you really are safer in long-term care, especially when you look at the death rate, than not being in long-term care. So a lot of people, they make a big deal about all the deaths that are happening in long-term care. But if you look at that, though, the rate is, you're safer in a long-term care setting. So just some little stats for you. And the way the health department's reporting this now, it's hard for me to pull out when we look at the facilities with COVID. It's hard for me to pull out whether it's employees versus residents. I used to be able to pull that out and get better statistics on it all, but now they're lumping it all together. So I wish I could do that better. So anyway, so just, I have a accounting degree, so I kind of like stats. I don't know if you guys like those or not, but anyway, there's that. Any questions? Okay. Things to think about. Well, I did bring my cards. And for those of you that were watching, it's still right here as well. So if you have any questions, you can email or call the office if there's anything on there. So thank you guys, and about 5 minutes.